I'm going to go through some of the things I think are important in documentation in the emergency department. And I'd love some input from some of the attendings and some residents. And let's jump right in. So this is my summary slide. This is what I'm going to talk about: the why and the how. That's pretty much it. All right, let's go into the why. Why do you care? Right? There's a lot of reasons why documentation is important. What's the most important one? Money, right? And this might seem silly. First of all, you should get into the habit of thinking about that now, because you're going to go out into the world, but also thinking about it now just for the fact, I don't know if you know this, but Kings County, downstate, they don't have a ton of money. And your documentation can help improve the amount of money they have. Now, does all that go into the resources we want? No, but it's hard to ask for resources when we don't generate the money. So it's easier, and it's really important to think about this. Now, we can sit and have 6 lectures on coding and billing. The most important thing to know is that the rules on this have changed this year for the much better for us. As an emergency medicine physician, documenting now for the purpose of making money is a lot easier. And it's really important to realize that. And I'm hoping that we can have some lectures on this, and we have talked about it a little bit, but I don't want to do that now. But it's really just realize how important that is for not only now, but also certainly when you go out into the world, because you're going to be talking about generating RVUs, and a lot of that's going to be based on how well you bill. Because 2 people who see the exact same number of patients, the exact kind of patients, can make a lot more money for their practice or the hospital than each other. All right, what else is important about documentation? Communication. How many of you, by raise of hand, have seen a patient and went back into the chart and then looked at their last ED visit and went and said, what the hell happened to this patient during that ED visit? Come on, how many of you? How many of you have looked back and said, I have no idea what happened to this patient. They were seen here, they might have had a 6-hour stay, and you have no idea what happened to them. That communication is important, right? You want to know what happened to them, what they were thinking about, because maybe it was 2 days later and you're like, oh, this was just 2 days ago. What were they thinking, right? Do I have to change the thought process? Do they have a thought process? What did they do, right? And that's really important. Communicating with each other is a really important part of documentation. All right. I promise you, you're all going to get sued. All right. It's just the way it is. And when you get sued, they're going to come and ask you stuff about your chart. And if it's not there, it didn't happen. You didn't think about it. You can be like, well, I thought about this differential, this differential, this differential. And they're like, well, you didn't document any of that. So how do we know that that's true? Right. And so if you didn't write it down, it didn't happen. So what you document counts. And also, it's very possible you might get sued 3 years after you saw that patient, and you will not remember anything about that patient except for what you wrote in that chart. So if you didn't document anything, you're not going to know what you thought. Right? You might not remember anything about the patient. So documentation is really important to remind you also in these scenarios, right? And QA, I mean, besides just, medical legal, but we review cases, the department reviews cases, the hospital reviews cases to make things better. And a lot of that is based on what we document in our charts. All right. So that is the why it's important. All right. So now let's get into the meat and potatoes, right? So how do we document, right? I mean, there's a lot of ways that you can document. There's a lot of, I think most people think a documentation should be kind of like a SOAP note, but it's kind of like an H&P at the same time. Like those are the notes you learn about in medical school, right? The SOAP note and the H&P. What we do in the ED is a little bit different, right? It's kind of like its own unique microcosm because everything's happening in that one moment, right? It's not a clinic note because we're not following these patients for 35 years, right? It's not a floor note because we're not following these patients for 3 days or a week, right? It's all happening right there. So sometimes your note has to be all that at once. But what should every note have? Every note should have a story, right? You should be telling a story. And I think sometimes we get so caught up with doing the documentation that we forget what our documentation should be, right? Telling the patient their story. They're like listening to their story and putting it down, and don't get pulled into the patient narrative, right? It's very easy for that to happen. You're sitting there, I don't think your note should include what they had for breakfast 6 weeks ago, right? But it's really important to say what happened to them now and what's going on with them today. And you have to tease that out from them and put that in the chart. But if you don't document that well, right? So I talked about the billing and how that's changed, right? And it doesn't really specify what happened. You don't have to hit 6 HPIs and 4 view of systems and this. You don't have to do that anymore, which is fantastic, but it has to be medically appropriate. So if you don't include the things that are appropriate, you can't bill for the complexity and make the money that you need, right? So telling the story, doing a good HPI is obviously really important, right? And what did you learn, right? And that's a lot of different things. That's a physical exam. So you don't have to document a certain number of physical exam, but you got to document a physical exam. So for billing reasons, you might not have to document anything, but it has to be appropriate. But certainly for communication, medical, legal, QA, all those things, your exam is really important, right? What lab do you do? Now, there's a lot of pulling in automatically. That's not the same thing as reviewing somebody's lab, right? So when your labs automatically fill into the chart, that's really dangerous. And we'll talk about that a little bit later of why that's dangerous for you when you're automatically pulling in information. It's not the same as interpreting the labs. And that doesn't mean you have to interpret every single lab. And I'll discuss that a little bit. And so that's labs, that's tests. That should all be in your chart. Everything that you did for the patient should be in the chart, right? And what's the most important thing? This is the most important. This is the thing that drives me nuts when I read a lot of notes, right? It doesn't include the thought process, right? You should have a differential in almost every single patient that you see, right? And I know you're thinking like, oh, every single patient doesn't need a differential. Laceration doesn't need a differential. It does, right? So you don't need a differential on what the laceration is, but you need a differential on what damage might have happened, right? So laceration, you have to discuss, is there foreign bodies? Is there neurovascular injury? Is there tendon injury? Is there a fracture, right? Those are all included. So it might seem simple. So obviously there's like fast track stuff, but you're not going to sit there and write a differential on somebody who stubbed their toe necessarily, right? But pretty much every single patient deserves a thought process, and it should be in the chart, because if it's not in the chart, it didn't happen. And you know what? I use my note to help me take care of patients, because by forcing myself to put my thought process in art, it makes me think about the patient. And, you know, we talk about biases. I'll talk to you about, to the end of the world, about biases and system 1 and system 2 processing. But by writing that differential, you're engaging, what I like to say, engaging your system 2, and that's a separate talk. All right. And so you want to include a differential. You want to explain what you're doing and why. And also, just as important, what happened to the patient, right? How many times have you guys read a note and it said, this is what's going on, this is what I'm going to do, and then the patient gets discharged. There's not even a dispo note, right? Because maybe you forgot to do it, but you have no idea what happened to the patient, right? And the patient could have been there for 12 hours, got 6 rounds of pain medications, a whole bunch of rounds of you know, Zofran, Reglan, Haldol, right? And you have no idea any of those things happen unless you sit there and tease through the chart, right? But it should be in your note. You should be documenting what happens to the patient. You should be there should be a beginning and an end to your documentation. Everything that happened from the start of the patient's evaluation to the end of the patient's evaluation should be in the chart. It shouldn't be something we need to figure out. All right. So how do you do this? There's not one way to do this, right? But I like to classify into 2 basic ways of doing your documentation, right? There's the one note for everybody, right? Like at the end, you just write a whole big note. And I think that's a little bit dangerous. I think for simple patients, it's fine. Certainly fast track style patients, some of the basic patients that we're seeing in the main ED, or that you see like that you just kind of like, you know, the basic chest pain, you did this, these are the results, you're done. It's all included in there. Your differential, your thought process is in that one note. But more complex patients should probably not just have the one note, right? And so I'm a big fan of the running tab. And I understand that it's not so easy to do in the emergency department. We're going to get through some pitfalls, right? And I want this to spur a conversation. I'd love to hear from attendings what they think about this and how they document. But I'm a big fan of, there should be the initial note with your thought, your history, physical, your thought process, what you're going to do, what you can do for the patient. And then for the complex patient, there should be progress notes throughout, and then a dispo note, an ending. There should be an ending, right? And I think a lot of times we forget about that ending. What happened to the patient? What do you think in the end? All right. And I'd like to go through some examples. All right. So here's our first example. For all these examples, I'm going to assume that there's an H&P history of physical that are done. Right. I'm just going to go to the assessment plan because I really think that that's the part that we are, you know, there's a lot of aspects of the note that we can talk about, but I don't want this to be a 4-hour lecture on documentation. All right. So how many times have you guys seen a note like this for your assessment plan? How many of you written a note like this? Don't nod your head. Just stick it in your head. Okay. right? So here's your assessment plan, right? And then whatever happens, happens. Here's the dispo note, and that's it. How many of you guys have seen that? Do you guys, what do you think? Good note, good documentation? So what would be another way you could document this the same patient, right? So here's an example too. Does that make more sense? How much longer do you think it takes to write this note? Is it a lot longer? Do you think it's 40 minutes longer? Do you think it's 2 minutes longer? Maybe 3 minutes? Maybe 5 minutes, right? And that seems like a long time, but it's probably worthwhile, right? And then here's a dispo for that same patient. This is not a dispo note I would ever write. Why is that? Does anybody know why I would never write this dispo note? Exactly. That's it. I would never opt test this. But I know this is a dispo note that a lot of you will write. So I'm realistic. I'm realistic. All right. All right. So what about this? Is kind of another example. These notes are not perfect. This is right. This is like, I tried to do the note in like 3 minutes, as if I was working in the emergency department. And then I can go back and be like, oh, I could have done this, I could have put this, and yeah, you can put a whole lot in. It's hard.
But also with like the Dragon that a lot of the rest people has access to it, this is gonna take you literally 1 minute. Like 15. So you can actually.
And I also think like sometimes like for these like ones, dot phrases can be really great. Be careful about dot phrases. All right, that's like you have to be careful about dot phrases. Simple, short dot phrases of things that you see often, which have like your differentials in it, and then you can go back and adjust it. So you're like your differential list for chest pain is always going to be kind of similar, right? Your abdominal pain, you can have a lower abdominal pain or an upper abdominal differential list. Those are all kind of, you can have dot phrase for that. Use that, right? There's techniques. I don't want to go into the techniques and how to document this. I really just want to go into the importance of doing this right? And then same patient, right? So you go back. If you go back, pretty much anytime you do something for a patient that's different than what you wrote originally, you should document that, right? Not only does it show that you're actually taking care of your patient, but if anything happens, it's important. It shows all the things that you're doing for them, right? It doesn't take long. This note does not take long. When you put in the order for the meds, the CAT scan, just go open up a quick progress note and just type 2 lines. You don't have to sit there and write the whole differential again. Just say, oh, I reevaluated the patient. They're still having pain. I'm going to give them some pain medications. You know, I'm going to order the CAT scan now, right? Yeah.
I just want to make one comment, because I think this is great to talk about, but coming off fresh years as a junior, sometimes I feel like this process gets prolonged for me because of my thinking. And it happened more as like an intern when I'm really trying to like figure out what I know and not knowing a lot. So sometimes like writing these notes and this thought process can take like 15 minutes, especially if I'm looking something up where I'm like trying to like dig a little deeper into something.
That's a great point, right? And I'm gonna talk about kind of the pitfalls, but as you know, that's kind of the next slide. So this is the dispo note for that patient. Any thoughts on it? Right? Fairly straightforward. It shows everything you've done. You've completed the circle, right? You've thought about the patient. You've documented what you did for them. You've documented what they haven't. You document how the patient feels. I think we forget about that a lot. We forget about our patients sometimes because we get so caught up in trying to finish the note and do the studies. Even if you do everything right, you're the nicest person in the world. You forget about closing that circle. Yeah.
I think this is a really good example of a nice dispo note to point out that the history of physical is not copied into the dispo note. I see it over and over again that people copy the whole entire history into their dispo note. And it's just a waste of time for people reading it and energy spent on it. Try and make your thought processes and not a rehash of the whole entire piece.
That's kind of what I was going for. All right. So obviously, this is not an easy thing to do, right? This is not something that's intuitive, right? It's not something you just show up into residency able to do, and it takes time. What are the pitfalls? So I think Sam brought up a really good point. This is our biggest thing pushing back on us on good documentation, right? Time. Time, right? Is your time, right? That's the hardest part of this. Let me ask you something. How many of you have been pulled into the principal's office because you're not seeing enough patients? By raise of hands. Oh, okay, good. How many of you have been told about something about your documentation might be something wrong? Probably more than a few of you, right? And so I think if you see one less patient on shift and document better and learn how to document better, I think that'll be okay, right? And that might not always be feasible. I understand that, right? But I think we shouldn't sacrifice quality documentation just so you can see that half a patient more, right? Or that one patient. I understand it takes time, right? And this is especially true for interns and juniors. If you're taking a little bit longer, this is not the lecture of you should be staying 3 hours after your shift to do this, right? I actually think you shouldn't be documenting anything after the patient has left the emergency department, right? That's my goal. When I see patients primarily, if I'm working somewhere primarily by myself, I'm trying to finish my documentation. Now, I understand that there's realities, right? I do work, right? I understand there's realities that this is not an easy thing to say, and it's not going to happen 100% of the time. But my goal is to finish documentation on the patient. And that's really, you know why that's really helpful besides then you're not having to stay late after your shift? You can cognitively offload those patients. Think about it. If you have 5 patients to write about, right, at the end of your shift, and that means that that's 5 patients during the second half of your shift, let's say, that you're still thinking about in your head. You still have to maintain, right? In your brain, you're thinking about those patients. If you discharge those patients and their documentation is done, right, or you dispo those patients, you can cognitively offload those patients. You don't have to remember what every single thing you found in the exam was, the details of the history. You can just offload it, right? So I think that should be a goal. It's not something you're going to accomplish. You might not even ever be able to do a shift completely by doing that. But if you try to do that on most of your patients, so you just have a couple of patients that are kind of lingering, you want to get that patient out because they're causing problems, just do the dispo, right? But at least I would say, try to do the assessment plan on the patient before you discharge them, at the minimum. Try to do everything before you discharge them, but at the minimum. All right. Now, this is also, we write too much sometimes, not me, but some of you, right? And I think at the beginning, it's okay to write a little bit too much, but as I was saying, like this, you have to find information that doesn't belong in the chart, right? Like what they ate, 4 days ago that might have contributed to their headache. It's probably not something you need to include in the chart. That's like not getting sucked into the patient's narrative and then just verbal diarrhea. Everything the patient told you just shouldn't go into your HPI. That's where your job is to process that and then put it onto the thing. Have you guys heard of this? No bloat? Some of you, have you guys heard of that? We live in an electronic age. EMR sucks, it's great. There's positives and negatives to both of it. I think note bloat is one of the biggest things one of the negatives that comes out of doing the EMR, besides sitting there and having to be on the computer for half of every single patient visit, right? And that's the automatic stuff that you can pull into the note. You can pull in all sorts of stuff. You can pull in every single thing that the patient has said to everybody. You can put in every single test result, and that's all in your note. That doesn't actually contribute that much to billing or coding. It doesn't contribute to it actually can increase your risk from a medical legal standpoint, because if you pull in all the labs and you can address one of them, you can't be like, oh, I didn't know that result. It's in your note, right? So if you're automatically filling things in, whether it's results or you have like these long dot phrases, if you're going to do that, you better go through it, right? But that's also time you're taking of going through it, right? It's also making the note pretty much unreadable. How many of you have looked at a note and it's full of all this stuff, maybe from other services, it's full of all this stuff, like the entire CAT scan read from beginning to end, including the little blurb from the attending and every single lab, and sat there for 5 minutes trying to find the 3 lines that the doctor actually wrote? How many of you done that? Raise your hands. Come on, all of us, right? We've all sat there, and that's what note bloat is, right? It also takes away from billing. It doesn't increase billing. It actually makes it harder for the coders to get the good stuff, right? Because you're filling with all that stuff. If you just write that you did some labs and document which labs, and if you that pretty much that's going to get you the money, right? So be wary of automatically filling in your note with stuff, and that's the note bloat, right? And what are some of the other pitfalls? Sign out, right? I've seen this, right? You get a sign out from a patient, you're taking care of them, right? You go assess them, you do this stuff, right? But you're so busy, right? You're taking care of your own patients, you got 6 other sign outs, right? And then it's like all sorts of crap happens, whatever. And then at the end of your shift, you got to sign that patient out again. How many of you have taken a sign out and then signed that patient out again and never written a note on that person? Come on, we've all done that, right? Never written a note person. Somebody spent 8 hours, you taking care of them, and you didn't document 1 second of it. Nobody knew that you were the doctor other than you were assigned to them, right? And putting in orders, right? And so that's really, like, you should be writing a note on every single sign out. You should be looking at every single sign out you get and then writing a quick note. Even if you just say, took over for this patient, and then, you know, a line, right? That just documents something, right? And then the last thing I think, discharge. This is another my pet peeves. I think a lot of us are pretty good. We write all this stuff in the discharge. Sometimes we're not, sometimes we are. This is a really important part of our patient care. Giving them good discharge instructions, closing that loop, as Kyle was talking about, right? It's a really important part. I'm a big fan of doing the the patient information on things, because it's a lot of them are well written, but you should read them. Like the common ones I've read, all like the COVID one still says there's no vaccine, right? Like, so just read those. But like, I'm a big fan of that. And I think a lot of people just think that they can write a couple lines, right? Like, oh, you have this, but like patients, they don't know what's going on with them. Hopefully you've talked to them, right? But by providing them information, and I'll say that, listen, I printed out a whole bunch of information on headache for you, right? And that's includes some information, like, it's not like complicated stuff, and they may never read it, right? And it might be a slight waste of paper. One day, maybe we could just, you know, text it to our patients, but it's really important, right? So providing good discharge instructions, documenting that discharge instruction, documented that you had a conversation with a patient about returning is really important, all right? And then don't lie. And I know, yeah.
That also, when you teach for patients, on let's say that they have a normal like lab or like a normal like CAT scan that you want to like follow up, I just print also all the results. That's a document that says ED to PCP provider that actually print everything. Because you tell the patients if you have a modulator thyroid, they don't understand. So sometimes it's like easier to just send the result.
100%. I do that all the time. If somebody has something that I really want them to follow up with their doctor, and you know their PMD is not here, I will print those results and give it to them. I think that's a really great point. Don't lie. And a lot of times we might lie and we don't even know it, right? That normal box, right? It's easy to click, but sometimes it's not normal and you just clicked it, or the things get written, right? Like a downstate, when you hit the cardiac normal, it says PMI non-displaced. Raise a hand. Who has checked the PMI on those patients? I sit and I delete that every time, right? Because I didn't check the PMI. That's lying, right? Right. And so it's be careful about lying, whether you know it or don't know it. So that's where that automatic thing comes in, right? When you have those dot phrases that say, you know, like, you got to be careful, right? If your automatic lower extremity exam says everything's normal, but the patient has a BKA, that's going to look really bad if anything happens. Whether it has anything to do with that or not, it just looks bad because now you're untrustworthy, right? So be careful about accidentally lying in charts. Certainly never lie on purpose. All right. So thoughts, questions, attendings, anything?